So thanks very much for the invite to present today. I'm going to do about a 30-minute talk on weight loss surgery, and then you'll be able to type questions into the question and answers box. And we will try to get to as many of your questions as we can. This is meant to be a little bit of a primer on how weight loss surgery works and what it all means, what the options are, and sort of an introduction to the entire process. So I have nothing to disclose, but I'm going to start with an important disclosure to start with that's going to probably surprise most of you. I don't really care how much you weigh, and I don't care before or after surgery. As you're going to learn from this talk, it's not about the number. It's not about how many pounds you lose. It's about how much your health improves. It's not the destination, it's the journey that I care about. And we're going to get into why that is. So let's start with some definitions. I always find this a great way to kick off this type of a talk. Obesity, the word, comes from Latin. And it comes from the Latin word obedere, which means to overeat. And it is a disease of excess body fat. Now, it is defined by insurance companies for actuarial purposes. So, for example, ideal body weight, which is ideal perhaps if you seek to be a supermodel, it's your mean weight per height at which mortality was minimum. And that, by the way, was determined by the Massachusetts Life Insurance Company. So ideal body weight comes from our own very Commonwealth, Massachusetts. Now, body mass index is a term we use more commonly. It's an almost 200-year-old term, and it's weight divided by height in meters squared. The example I like to use is the basketball player Shaquille O'Neal. I said to you, well, geez, Shaquille O'Neal weighs 320 pounds. You go, gosh, that's kind of big. Then when I tell you he's 7'1", you realize he's not even obese. So weight divided by height squared is a more accurate picture of measuring how obese someone is. Now, morbid obesity as a disease was introduced by the surgeon Howard Payne in the late 1950s. And ironically, his goal was to get paid to do obesity surgery. So even 60, 70 years ago, we were fighting with the insurance companies to appropriately cover patients' needs. The problem is it's a grammatically flawed term. It should be morbidly obese, not morbid obese. And it's pejorative. What does morbid mean? Who in the audience feels very morbid right now? And it's also not well defined. What is the difference between just plain obese and morbidly obese? Now, in terms of defining things of importance, bariatric surgery is another term for weight loss surgery. And bariatric comes from Greek. Baros means weight. Iatria means medical treatment. So it's barosiatria, bariatric. It's the medical treatment of weight. Now, this sometimes gets confused with hyperbaric medicine. Hyperbaric medicine is, for example, something someone would need if they had the bends from surfacing from scuba diving too fast. It's also used to treat wounds. But the baros is the same etymologic root. So there's reason why it's confused. And what bariatric surgery means is it's surgery in the morbidly obese patient for the express purpose of producing weight loss. So we call it morbid obesity surgery. And you'll hear gastric bypass. We'll talk about that. Stomach stapling, that's another term that's used to describe all the same thing. Now, why are we obese? In full disclosure, none of these companies sponsored this talk. Calories in minus calories out equals weight gained or lost. On average, Americans gain 10 kilocalories per day. It's a kilogram per year. That's 2.2 pounds per year. That's a pretty staggering thought if you think about it. Now, this quote is over 150 years old, and I really like it because it's relevant today. Even though obesity can result from deficiency of a key gene involved in the regulation of energy balance, the epidemic of obesity is driven primarily by how we live. Now, let's think about that statement and unpack it a little bit. An epidemic is an infectious disease, so he meant that whimsically. But if you look at the rate of rise of obesity in this country, it's spreading at epidemic rates. Certainly, this is a term we're all familiar with the recent pandemic of COVID-19. So obesity is rising at epidemic rates. And it's driven primarily by how we live. It's our behavior. Now, genes are involved. It's very rare that you see someone who's morbidly obese with two parents who are skinny as a rail. So genetics play a role, but our behavior plays a role as well. That was recognized over 150 years ago, which is pretty staggering to think about. Severe obesity is an involuntary disease, and it affects actually nearly 30% of the US population. It is chronic, it's progressive, it's debilitating, and will lead to an early death. It's the most prevalent disease process in the United States. It's nearly 8 times more prevalent than heart disease. These are all complications of obesity. Think about this. High blood pressure, heart disease, sleep apnea, diabetes, cancer. There's a bunch of cancers that have a significantly higher rate in the obese population. We're not talking rare ones. We're only talking about things like breast cancer, colorectal cancer, prostate cancer in men, ovarian cancer, much higher incidence in the obese patient. Major joint and back pain, sudden death. Did you know that you have a 4 times increased risk of suddenly dying if you're morbidly obese? How about hyperlipidemia, like high cholesterol and high triglycerides? Oh, there's more though. Asthma, gastroesophageal reflux disease, infertility, depression, anxiety, stroke. And then there's what I call the hidden comorbidities of obesity. Things like social rejection, loss of jobs, or failure to get a promotion in jobs, loss of mobility, and a downturn in quality of life. So this is a staggering disease with consequences across every body system and that have significant psychosocial ramifications. But the treatment options, put simply, stink. Diet. If we were in person, I'd ask for a show of hands for who's been on a diet. You don't have to put your hands up at home, but I know you've all been on diets, many of them. Exercise, easy to say, harder to do, especially when your joints hurt every time you move. Behavior modification. Okay, you can do things like not binging or not standing in front of the refrigerator eating. These are all helpful tips, but that alone isn't going to fix the problem. And there are a bunch of medications, especially a few newer ones that are very promising, that may play an important role in the treatment of obesity going forward, but they alone are not going to cause significant enough weight loss. So here's the reality. For the patient with severe clinical obesity, 100 pounds over ideal body weight, there's nearly a 100% chance of failure over a 3 to 5 year period. We can lose the weight. I'm sure all of you have done it. The problem is it tends to find us again. We just can't keep it off. So we relocate the weight, but it comes back. So there are 2 prominent surgical options that are done today at Baystate Medical Center and at most hospitals. The sleeve gastrectomy, which is this operation you see on the left, is the most common operation. And put simply, we divide the stomach and we take out about 2/3 of it, leaving a small gastric tube. This is a newer operation that's been around for about 10 to 15 years. The gastric bypass has been around since 1967. And in fact, the surgeon who invented it recently died at the age of 100 just a few months ago, Ed Mason. And in this operation, we divide the stomach into a small gastric pouch, and we divide the intestine, and we bring the intestine up to that gastric pouch, and we reroute gastric juices and bile and pancreatic juices into the intestine much further downstream, causing us to digest inefficiently. So the sleeve gastrectomy only limits the volume of food. The gastric bypass limits the volume of food and causes maldigestion. Now, this isn't to be confused with some other operations that are no longer performed or less commonly performed. Vertical banded gastroplasty, very popular in the 1970s and 80s. We don't do it anymore. I'll get into these in detail in a minute. A lap band, many of you are thinking, what happened to that? That's now a goner. Gastric balloons are out there, not commonly done. Let's talk about why. Gastric banding or the lap band, way too much work for you, way too much work for me. Not enough pounds lost, and eventual intolerance leads to almost a 100% removal rate. I put in probably 1,000 lap bands between 2005 and 2015. I've taken most of them out, or other surgeons have taken them out. The problem with gastric banding is that over time they become really annoying to the patient and difficult to live with. So too tight and you can't eat anything and you cause vomiting, too loose and you don't lose any weight, and if anything, you gain weight. But that in-between zone became impossible to achieve, and so the bands needed to be removed. There is an operation called the duodenal switch, and duodenal switch is not performed at Baystate, and the reason is because it causes a lot of malabsorption. People that have duodenal switch can get into very serious vitamin and mineral problems. And so for that reason, it's not offered here, but there are other hospitals that do offer it. It causes the best weight loss of all operations, but in the expense of malabsorption problems. Vertical banded gastroplasty was kind of the rage in the 70s and the 80s and even into the 1990s, but it's all been abandoned. There's too much weight regain. And then gastric balloons are something that are out on the market and approved by the FDA, but it's essentially weight loss by chronic nausea and vomiting. Doesn't seem very pleasant, and it's not covered by insurance, so it costs tens of thousands of dollars out of pocket to a patient. And these are temporary. They can only stay in for 4 months, then have to be removed. And as you might imagine, you take the balloon out, the weight gain comes back. So we don't offer those here at Baystate. Let's talk about what we do offer at Baystate, and that's the sleeve gastrectomy. It's performed about 85% of the time in the world for weight loss surgery. Digestion remains normal. So once food leaves the stomach, digestion proceeds as it does currently. It limits the volume of food one can eat in a meal. So your meal sizes will go down. You'll take in less calories in that meal, and you will feel full after that meal, which might be new for a lot of you. Although some of you may think you feel full, wait until you have a sleeve, you'll realize you really never did feel full. I believe the reason why people are morbidly obese is that they never turn on the fullness switch when they eat. That's a brain problem, and unfortunately we don't know how to fix, so we do stomach surgery instead. Now, with the sleeve, there's no penalty for poor food choices. In other words, you can eat whatever you want. You can expect to lose about 50 to 60% of those pounds overweight, and that happens in about 18 to 24 months. Complication rate is pretty good for sleeve gastrectomy, about 3 to 5%. The three major things that happen are a leak from the staple line, where the staples that close off the new wall of the stomach fail to heal correctly. And that takes about 6 to 8 weeks to heal. And that means 6 to 8 weeks of no eating, no drinking, and getting all your nutrition through an IV. So fortunately, it's rare. It happens 1% of the time, but when it does, it's a big deal. You usually can't operate on it because the tissue is too inflamed to hold sutures. So the patients just tend to re-leak again. Bleeding happens about 1% of the time, particularly from the spleen, because the part of the stomach that we take out is often connected and attached to the spleen. And the spleen is a giant bag of blood, so it doesn't like it very much when we do that. You can get some bleeding. Strictures can happen about 1 to 2% of the time. That's where the sleeve becomes too narrow to permit food to go through. And if that were to happen, you have to be dilated with an endoscope by a gastroenterologist, or sometimes if that fails, we have to convert you to a gastric bypass operation. The one main consequence of sleeve gastrectomy is that gastroesophageal reflux disease is very common afterwards, and I put everybody on anti-acid medicines. Long-term can be up to 20 to 30% of patients. This is the one thing that over the next 10 to 20 years could doom this operation. People start having consequences from chronic reflux disease. This operation may go away and we may be back to gastric bypass full time. So it is something we worry about and think about. Now, what's the recovery like from this? It's 1 to 2 days overnight in the hospital, generally 2 weeks out of work. It takes about an hour to perform, so pretty fast. You get to have clear liquids the day of the operation. You're on clear liquids and protein shakes for about 2 weeks, and we start the protein shakes the next day. You then are on about a soft food, a sort of a soft modified diet for 4 weeks after that, and then you're on a regular low-calorie diet. As far as exercise, you can start walking right upon discharge. And cardio work after about 2 weeks, but no core work like yoga or weightlifting that involves your core for about 6 weeks. So in a nutshell, this is the keep it simple, stupid operation. If you want to lose weight, I'll make your stomach smaller. There's nothing more complicated than that. There's no maldigestion or malabsorption. So the good news is you can eat whatever you want afterwards. The bad news is you can eat whatever you want afterwards. So it's on you to make good food choices. You're not going to have your stomach remind you. It's clearly the safest option with regards to complications. So it's simple, it's safe, and there's no maldigestion. Now, gastric bypass is a whole nother story. So let's talk about it. It's still considered by some to be the gold standard. It's certainly the oldest weight loss surgery operation. It's been done since the 1960s. And laparoscopically, through the small cuts with the TV camera, which is how we do most of our abdominal surgeries these days, that's been being done since 1993. So we're approaching 30 years of laparoscopic gastric bypass. It limits food intake and forces the absence of sugar from your diet. We're going to get into this in more detail, but you get a big penalty for cheating. It's called the dumping syndrome, which sounds about as pleasant. It is about as pleasant as it sounds. You lose more weight, 60 to 70% of your excess body weight. The fullness effect is less pronounced than the sleeve. A lot of my sleeve patients will tell me they eat breakfast and they're not hungry again until dinner time. Think about that for a minute. Now, they do eat lunch because they are told by their dietitians they need to, but honestly, from a hunger standpoint, they could skip lunch every day. That's less the case with gastric bypass. And this operation may be better for diabetics and for patients with hiatal hernias. So there are times when gastric bypass is simply a better choice due to your other medical problems. Much higher complication rate. Still about a 1% leak rate, but it can come from different places, the gastric staple lines or between the stomach and intestine connection or the intestine itself. And this often is fixed with another operation. Bleeding again about 1% of the time. The opening from the stomach to the intestine can stricture about 1 to 2% of the time. It can be even more than that, depending on how you do the operation, but generally about 1 to 2% of the time. Internal hernias that can cause bowel obstruction can happen up to 5% of the time, and that requires another operation. Vitamin and mineral deficiencies, mostly iron, but rarely vitamin B12, folic acid, or calcium, up to 10 to 15% of the time. Ulcers can happen 1 to 8% of the time, and that's many, like 30 times higher in smokers. So it's rare to see in non-smokers, common in smokers. Intussusception, which is kind of a complex problem, but think of it as a loop of intestine telescoping itself into another loop of the intestine. And that can happen up to 3% of the time and usually requires an operation to fix. It's 2 to 3 days in the hospital, it's 3 weeks out of work, and 3 hours to perform. So this is a much more extensive operation, harder to perform, harder to recover from. Similar dietary progression as the sleeve as we described, and diabetics may actually see their blood sugars get better while they're in the hospital. In fact, some people that have to take insulin might be off insulin as soon as 3 days after the operation. So it does take some monitoring of your sugars, careful monitoring to make sure that they don't fall too low. And similar exercise progression, these are done through the same incisions, so that doesn't change. So why is it less common? Well, because it's got a much higher complication rate, 25 to 30% if you follow your patients out far enough. The long-term ramifications and the long-term reoperative rate is significantly higher, and so that's led surgeons and patients to be less excited about this. Some of those vitamin and mineral problems can become debilitating. For women with iron deficiency anemia before gastric bypass, if they were to have a bypass, the anemia can become so pronounced they have to get intravenous iron once a month. That doesn't sound too pleasant, so it's something we have to worry about. It's hard to do, so surgeons tend to shy away from it because it's very technically complex. This is the Mercedes-Benz of abdominal operations, but not everybody wants a German car. Dumping syndrome, again, we'll talk about it in more detail in a minute. It's not very pleasant, and it's much more work for the patient as well. The diet is a little bit more complex. What are some of the consequences? Dumping syndrome is an intolerance to sweets, which means you basically can't have any sweets in your diet. Lactose intolerance. Gastric bypass can unmask underlying lactose intolerance. A lot of obese patients are already lactose intolerant. This makes it way worse. You can have temporary hair thinning. It's a partial loss of hair. It does tend to get better. I call it Romanelli's revenge for obvious reasons. There's a lot of psychological adjustments that come with gastric bypass. You lose 150 pounds, people look at you completely differently, but that may cause significant anxiety or discomfort, and that's something that you might need to think about. There's a need to take antacid medicines and vitamins and minerals, and sometimes that's not covered by insurance. And there might be a need for plastic surgery afterwards, and that's often not covered by insurance either. So these are all things you have to know about if you're getting gastric bypass. All right, so let's say you're interested. I want to talk a little bit about how the program works. So it takes about 6 months or even longer to get through the program. We don't want impulse buyers. I don't want somebody to say, that's it, I've had it, and show up in a week to get their surgery. You have to attend support groups, and generally these are held monthly. The good news is, since the pandemic, they're largely online, so you can do them from home or even from work. So it's a little bit easier to attend them, but we ask you to attend at least one a month for at least 3 months. You have to see a dietitian for a bunch of visits and eventual clearance. How many is dependent on your insurance company. Same thing with behavioral health. You will need to be cleared by the behavioral health team to make sure that you are psychologically ready to handle the mental rigors of completely changing your diet. You'll meet the surgical physician assistant and later your surgeon. You'll be seen by the sleep medicine team and evaluated for sleep apnea. And if you have it, you need to be treated for it. They'll eventually clear you for surgery. You'll need medical clearance and or optimization. So for example, if you have diabetes, but your hemoglobin A1C is very high, suggesting that you don't have very good blood sugar control, well, we would need to get that controlled before you underwent surgery electively. If your blood pressure is very poorly controlled and you come into my office with sky-high blood pressure, that would need to be controlled before it would be safe to operate on you. And then all the fun things in life, like cigarette smoking, marijuana smoking, or alcohol cessation, needs to be stopped before you would go through to be cleared for the surgery. And the thing is, the insurance companies require this, but I don't fight it because it actually is best practice. So these are all things that you'll need. And think about this. Let's say you're 40 years old, and let's just do, simple math because I'm a simple guy. So let's say that, I'm just going to say a year has 350 days in it for simplicity. And you eat 3 times a day, so we'll just round that down to 1,000. So you've eaten 40,000 times a certain way. And now I'm telling you, you have to do it differently for the rest of your life. This is not something you can do with just 1 week or 2 weeks of preparation. Think of it like this. If I told you you need to start running, you could practice and start doing that and warm up and go stretch and go jog for a little bit and work your way up to running a little bit. What if I told you you need to run a marathon? That's 26 miles. You couldn't just go out the door and go do that. You'd have to train for that for many months. So this is a marathon. It is not a sprint. We are seeking a lifelong change in your quality of life and how you eat, how you get your nutrition. And so we have to train you to do that. And that's what all this does. Now, there's a couple of important takeaways. Obesity is a chronic lifelong disease. Left untreated leads to earlier death and the development of significant comorbid diseases. But yet the medical options to treat it aren't very good. So I don't mean to paint a negative picture. I mean to paint a real picture. You need to understand that nobody that's listening to this seminar tonight signed up for this. No one chooses to be obese. It's a disease. It's not poor eating habits. It's not poor behavior. It's not an inability to stay on a diet. It's a disease. And you have to understand that surgery is just one tool out of many to fight this chronic disease. I like to use the golf club analogy to explain this. If you go to Dick's Sporting Goods and you buy a $300 driver, the tailor-made X11, whatever it might be, and you can't hit the golf ball very far, they're not going to give you your money back, because it's how you use the tool that determines the success. Okay, but surgery might be the driver, but you're going to need your woods, your irons, your pitching wedge, your putter, all of them to play the round of golf. And for weight loss, you need all these tools. You need surgery, but you need the diet, and you need to exercise. You need to change your behavior. You need to take care of yourself medically. All of these tools working in concert together leads to success. The operation doesn't do the work for you. I remember when I would put the lap bands in people, and patients would come back to me and go, the band isn't working. Well, the band doesn't do anything. You do the work for you. And that's very important for you to understand that. I'm going to give you a tool to help, but you have to do the work. The ability to exercise increases profoundly when the weight comes off, so do it. Right now, the idea of walking 2 miles might be laughable to you because your knees hurt so much, or your hips hurt so much, or your back or your feet hurt so much. 50 pounds from now, that pain may go away. So if you have the ability to exercise, do it. Eat well, but eat right. This doesn't mean you can never go out to a restaurant again. Doesn't mean you can't eat quality food again, but make good choices. And taking care of your mental health is critical. If you turn to food to escape life stresses, you're going to need to address that before it's appropriate to do surgery, because I'm going to take food away. If your two best friends are Ben and Jerry, we're going to need to address that before we talk about completely changing the way you're going to eat the rest of your life. We all have stressors in life. Many of us have a sick or dying parent, a sick or dying child or sibling, stress at work, marital problems or relationship problems, or other stressors, a stressful past, maybe, having served in combat and having post-traumatic stress disorder, abuse histories. These need to be addressed with mental health professionals before weight loss surgery can work for you. Very important. Keep this in mind. It's really important. It's not about the destination. I don't care how many pounds you lose. It's about the journey and getting you to a higher quality of life. Sure, I expect you to weigh yourselves and I expect you to know how many pounds you've lost, but I don't measure your success based on how many pounds. Measure your success based on how healthy you are. I measure your success based on your life successes. I remember one lady very vividly early in my career, 20 years ago. It was actually when I was in practice in New Jersey. She was a recovering alcoholic. She was a recovering cocaine addict. She weighed about 350 pounds. She was working for one of the cable companies and had kind of moved up the ladder, and then her career sort of stalled. And twice she got passed over for promotions by people that she felt were significantly inferior to her in terms of ability and work product. She was 41 years old. She was never married. She had a gastric bypass. She lost 150 pounds. She got promoted not once, but twice. And both of the people that got promoted over her, she got promoted over, and both were eventually fired. She ended up getting engaged to another weight loss surgery patient and got married. And all that happened within a year and a half of her operation. So was the 150 pounds the important part, or all those positive things that happened to her life what was most important? So that's what I care about, and that's what I celebrate. I told you in the beginning, I don't care what you weigh or how much you lose, and it's true. If I said to you, would you go on a roller coaster if it was 80 feet high? You might say yes. Or if it goes 60 miles an hour, you might say yes. But if I said, well, if it's 100 feet high, would you not go on it? Or it goes 70 miles an hour, would you not go on it? I just care that your weight is going down. I don't care how fast or how much. I don't care how much you lose. I care how much healthier you are. The big picture is really important here. And as your doctor, it's my job to focus on the big picture. You can fixate on every pound all you want. I don't care. But I do care about how healthy you get. And that's what this is all about. We're not talking about weight loss. We're talking about health improvement. So this is a big deal. You're preparing for surgery, so take care of yourself. Start a multivitamin. Get on a high protein, low fat, low carb diet, and your dietitians will teach you how to do that. Get plenty of rest. Make sure you're getting enough sleep at night. Stop smoking. Control your blood sugars. Take your prescribed medicines. See your primary care doctor and talk about this. Don't do this as a surprise. Don't gain any more weight. I want you to avoid the Last Supper syndrome. What is that? The thought process of, I'm never going to eat again, so I better get it all in now. Don't do this. Rapid weight gain can cause insurance to deny your surgery. It can increase your chance of complications. It might mean you have to have an open operation instead of a laparoscopic one because your liver is too large. And it might complicate your postoperative course. So you don't want to do that. And I kept teasing it, so I do want to talk about this. Dumping syndrome. It follows many types of stomach surgery, so not just weight loss surgery. It's what happens when larger sugars rapidly arrive in the small intestine. And this can vary in incidence and intensity, but generally sweating, feeling weak, feeling your heart racing, nausea, maybe some vomiting, some hot flashes, diarrhea, lasts up to 1 hour, but I didn't spell this right, sorry about that, but severe cases can last up to 8 to 12 hours. Pretty significant. This is awful. The good news for this is mostly in bypass patients. Sleep patients don't tend to dump. Good news, bypass patients, it helps you to avoid sugars. Romanelli's rule, every gastric bypass patient dumps once. Very few ever do it again. I want to make one last comment about pregnancy. Women of childbearing age should try to avoid becoming pregnant for 24 to 36 months after weight loss surgery. You want to wait until the weight loss stops. In other words, you're at the bottom of the roller coaster. Rapid weight loss and nutritional deficiencies can harm a developing fetus, and it can even cause miscarriage. So should you become pregnant in the postoperative period, notify your dietitian right away. It's also important to note this. Two things increase the risk of pregnancy. One is that if you have infertility problems, they can rapidly reverse, especially after gastric bypass. The second is that it's very common as you lose weight to gain self-esteem. So, sexual activity tends to increase in the weight loss period because you feel good. Your body feels good and you feel good about yourself. So your interest in sex is going to go up. So be very careful because pregnancy can happen even if you don't intend it. So it's important to talk about this. I'm going to stop at this point and I'm going to answer questions. I think you've heard me blab on long enough. It's been about 30 minutes. So we're going to stop sharing my screen and I'm going to take questions if you have any.
Thank you for that presentation, Dr. Romanelli. That was really inspiring. Thank you. I mean, really terrific. And there was some really great nuggets of information for people wherever they are in their journey with their body. I don't see any questions yet, but we can give it just a few minutes and see where we're at.
Well, one thing I'll bring up while we're waiting for some questions. I have a lot of patients who raise concern about this because this is viewed by other people to be the easy way out. I want to caution you about a couple things. One is that surgery is never the easy way out. It hurts to have operations. You have to miss work for a period of time. You have to recover. Complications can happen. You're at risk for complications down the line. It's very much the hard way out. So re-educate any skeptics in your life by saying, you know what, surgery is never easy. That's one thing. The other thing is it's not the easy way out. It's a smart way of addressing a chronic disease that doesn't have a medical cure. So thankfully, we have surgery that can help somewhat, but it's by no means easy. And that's why it takes 6 months or more to get through the program. We're preparing you for a big deal. So for people who try to tell you it's the easy way out, they couldn't be more wrong, and feel free to educate them that that's not the case.
Thank you for that. We do have some questions coming in. I just want to make mention that, Heather, you said you had 2 questions, but I don't see them showing up in the Q&A box. So if you could retype those, that would be great.
Yeah, I don't see anything in the Q&A box. I don't know if it needs to be able for me to see it. But in the meantime, you can feel free to read them for me.
Yeah. Yeah. I'll read them to you then.
Okay.
Marissa's asking, how will I know which surgery would be best for me? Is that something I decide, or would it be something that's discussed?
So it is the epitome of a concept that we're really getting better and better at in medicine called shared decision making. And I believe that all good medical care comes from shared decision making. This is a decision that you, the patient, and me, the doctor, make together. And it happens through a well-informed process, of which this talk is part of it. We talk about it and we discuss it. And you'll talk about it with the physician assistant when you meet him. His name is Steve Young. You'll talk about it with your dietitians. You'll talk about it a little bit with your behavioral health specialist. But it's an ongoing dialogue for several months. You'll start the process if you decide you want to undergo this journey with an information session that drills down into even more detail about these procedures. This was just kind of an overview tonight. So you'll kind of form your bias as to which one you think sounds right. And then when you meet with your providers, you bring that up and you come to a conclusion. A lot of times people don't decide until several months in the process, but interestingly, most of the time patients know ahead of time. They come in with what they want, and because it's elective, my inclination is as long as it's medically safe and reasonable, whatever you want is what I'm willing to perform.
Excellent, thank you. Well, there's quite a few questions coming in now.
Good.
Dennis just had a comment. Great presentation, doctor. Thank you.
Thanks, Dennis.
Diana said in one of the slides referring to gastric sleeve, it states NPO for 6 weeks. Does that mean no solid food? The bullets following discuss liquids, shakes, etc.
Yeah, no, not nothing to eat or drink. We have you for 2 weeks on liquids and protein shakes, and then we start you on a modified diet for 4 weeks. Then at 6 weeks, you're unrestricted and you can eat regular food, low fat preferably.
Thank you for that. Haley wants to know what percentage of people gain the weight back after surgery.
Yeah, great question. Thanks for asking that. Too many, in my opinion. It's about a third. I would say the best way to describe it is a third are smashing successes, a third have significant degrees of success, and a third tend to regain their weight back. Keep in mind, it's a brain disease, right? So I'm doing a stomach operation on a brain disease. So the brain is going to try to find ways to outwit my operation. So it takes a lot of work to not allow that to happen. Sometimes we're not always successful.
Oh, excellent point. Amanda would like to know, how much does life expectancy increase?
Yeah, that's an awesome question. Thanks for that, Amanda. It's unknown, but there are they have statistical modeling that can kind of suggest an answer to that question. And the modeling that I've seen suggests it may be as much as 10 to 11 years. So that's pretty significant.
Wow, that sure is. Is there any data on how many people see comorbidities go away after surgery?
Extensive data. Thank you. Who asked that question?
That was Amanda again.
Amanda, thanks. That's your 2 for 2. Great questions. Yeah, there absolutely is data on it. So gastric bypass patients, about 85 to 90% will resolve high blood pressure and diabetes, and about 90 to 95% will resolve sleep apnea. Sleeve gastrectomy is still about 80 to 85% for the hypertension. It's in the 70s for diabetes. Sleep apnea is up in the 80s as well. Gastroesophageal reflux is virtually 100% with gastric bypass. If anything, it may worsen with sleeve gastrectomy, so I wouldn't say that's as successful. But the big ones are high blood pressure and diabetes, over 75% with both operations.
Excellent. Diana is asking, is it common to need only 2 weeks out of work after gastric sleeve?
Yes. Week of sore and a week of tired. As I tell people, you can't watch the chew anymore, so there's nothing to do but go back to work.
Very good. Kim would like to know, would you recommend weight loss surgery for someone who was successful in losing some weight, but had plateaued and has been unsuccessful in losing any more?
Absolutely, positively. So you're actually the people I want the most because I know you can do it. I'm just going to give you help and make it more realistic. And that's what the surgery does. But that proves to me that you understand how to make behavioral change and dietary changes. And those patients tend to be the most successful after weight loss surgery. So, in fact, your insurance companies want to see that you've tried to diet in the past. So that actually is a step in the right direction towards this journey.
Excellent. Heather says that she's currently on Coumadin for pulmonary. Oh well, I shouldn't say that. In May, can surgery be done on Coumadin?
No, it has to be stopped. Coumadin is a blood thinner for those that are unfamiliar with it, And so we do stop it. What we do to manage it depends on the reason why you're on it. And that's, a little bit too much detail for this conversation. Sometimes we give you shots of a blood thinner that you have to take before surgery. Other times it's not necessary. So it depends on the reason why you're on Coumadin. But no, we have to reverse the Coumadin to safely operate on you, or else it would be a reasonable expectation to have significant bleeding afterwards.
Heather would also like to know, is there a weight that is too heavy to have the weight loss surgery?
Awesome question. Yes, 450 pounds is my upper limit. And the reason for that is because we lose the capability of getting radiology studies above that weight. So if I operated on a 500-pound patient at Baystate, I can't offer him the same care I can offer a 400 or 300-pound patient. And I think that's ethically problematic. So what we do for people who are over 450 but are interested in weight loss surgery is we work with you to try to get the weight off medically beforehand. At the current time, we don't have a sister or partner program to send you to, but good news, there's one coming hopefully in the next 3 to 6 months.
Diana would like to know what criteria would rule someone out for gastric surgery.
I don't know that it's hard and fast yes or no criteria. There are some disease processes where it's not as advisable. And I don't want to get too much into specifics in this webinar. It's pretty rare that you can't have it. The major thing that would knock you out of the box is prior esophageal or gastric surgery. So for people that have had stomach surgery before, they may not be able to have weight loss surgery. People that have had a lot of abdominal surgery before, it may not be technically possible. And sometimes people with very large hernias, it may be difficult to do. But other than that, there aren't too many that would be, not possible. Severe heart disease and people with a really bad heart may not be able to undergo an operation of this magnitude. So I would also say there are some medical conditions where you're just too sick and it's not safe.
Thank you. Georgiana would like to know, what about a gastric bypass revision? Do you do that?
Great question, Georgiana. I thank you for asking that. In general, no, for a very simple reason. It would be like having that bag of golf clubs and buying a second driver and expecting that your golf score would get lower. Once you have gastric bypass anatomy, there's really not a lot I can do to change the anatomy that will significantly impact weight loss, and it's high risk. So it will be entertaining a lot of risk for not a lot of benefit. There are sometimes anatomic complications of gastric bypass that, if addressed, might lead to more weight loss. So it's my job as the surgeon to look and see if there's an anatomy problem. But if the anatomy is the way the original surgeon made it, there's really not a lot I can do surgically to reintroduce weight loss. And I think this is where dietary medications really may play a significant role. And of course, for that, we need to have our partner program that we're in the process of developing.
Thank you. Miguel asks, what about if I only have to lose 20 pounds, how do I do it? I'm 73, currently 186 pounds and 5'8".
Yeah, so thank you for that, Miguel. So this is not for you. This is for people that need to lose about 75 to 100 pounds. And so these types of operations are not for you. You would not qualify. If I wish I had the easy answer, because I need to lose 20 pounds. So if I figure it out, I'll give you a call. But the reality is good food choices, not overeating, getting regular exercise. Even at 73, you can do that, even if it's going for a walk once a day. You got to try to burn more calories than you take in. Easy for me to say, a lot harder for people like Miguel and me to do. So I totally understand that, but it's diet and exercise, my friend.
Thank you. Would you recommend taking, I'm sorry, this is Kim. Would you recommend taking medications for weight loss before going through the surgical route?
Well, let me split that into two questions. Can you do weight loss medications? You're welcome to do those at any time. However, in the program, we ask you to stop them. because number one, the insurance companies generally will not approve you for surgery if you're on a weight loss medication. But also number two, we want to know if our interventions are making you lose weight or if the medicine is making us lose weight. So it confuses the picture. So in order to get a clearer picture, we ask you to stop them when you're in the program. But, you know, if this is something where you're thinking about surgery maybe in 3 to 5 years, and you want to try medicine for a couple of years, by all means, talk to your doctor. No reason why you can't do that.
Sure, thank you. Heather would like to know, is there a weight that is, oh, wait a minute, I'm sorry. I think we already asked that one. Oh, Evelyn would like to know, how dangerous is it to regain weight, and how can you regain if the stomach is smaller?
Yeah, remember what I said about the brain trying to outwit our operation? That's the answer, is that the brain finds a way. And we have to fight those tendencies. And you're right, it amazes me when I see people that regain their weight after gastric bypass, and I do radiology work to determine what the anatomy is, and it's the same anatomy as when they were freshly post-op. Frankly, as a surgeon, it's maddening, and as a patient, it's frustrating, but it can happen. What I would tell you is do your part, which is make good food choices, avoid bad food choices, avoid the empty calories, don't drink carbonated beverages. I know it's nice to have a beer on a hot summer afternoon, but when you're trying to lose weight, it's the wrong thing to do. Avoid sweets, avoid empty calories. Listen, we all like Dunkin' and Starbucks, but you know what? They're a big contributor to this problem. Coffee is an absolutely devastating way to get empty calories. So you got to avoid those temptations, and it's hard because they taste good, they're enjoyable and pleasurable. But if you're trying to lose weight, you got to commit to it and avoid those things. So I would say cut out, if it tastes good, don't eat it.
Good one.
If everything tasted like kale, we wouldn't have this webinar tonight. We'd all be skinny.
So true. But hopefully everyone is feeling inspired by everyone else and your comments tonight. Tona Lee is saying that she was scheduled and she failed for nicotine for her surgery, and she wants to know how she can get back into the program. And she does have a hernia too.
Yeah. So we'll skip the hernia conversation because that's getting a little too personal for the purposes of the webinar. But once you've been a non-smoker for 3 months, come back, please, because you're eligible again. So we're only asking for 3 months of no tobacco. And that there is science behind that when you smoke, it causes bad effects to the respiratory system, and those reverse within 3 months. And it also causes problems with the microvascular circulation, which can affect how tissues that we operate on heal. And so after 3 months of no smoking, those bad side effects tend to go away.
Evelyn, thank you for that. Evelyn would like to know, what would make an insurance company not pay?
Their desire to pay their CEOs $400 million a year. You have to meet their criteria for this. They don't want impulse buyers either. And if they're going to invest the money in you to get an operation, they want to see you succeed. And actually, they're in the vested interest in your success because you'll cost them less money as you get older and sicker. So they actually are on your side, but they're not going to just give that money away. So you got to do work to prove that you deserve to have this and want to have this. And so not following the rules is the answer to the question. They're not my rules. I don't make the rules, but they do emulate best practice. So I'm also not opposed to those rules.
Right. Excellent. Haley would like to know, does bypass surgery affect the absorption of medication? And if so, does the medicine dosage change after surgery? So it absolutely can. And thank you, Haley, for that question. That's a really good question. It can. And in fact, there are some disease processes where that's a potential problem. For like somebody say that had a kidney transplant, could it affect the absorption of their anti-rejection medicines? Maybe. So anytime there is a question of medicine absorption, sleeve gastrectomy is a safer choice
because the intestine is totally unchanged. So unless it's dependent on the stomach itself for absorption, and most medicines are not, you can pretty much absorb anything after a sleeve gastrectomy. So when in doubt, sleeve.
Thank you. Tony Ali, who was asking about getting back into the program, said that this was in 2009. Is she still eligible?
Yeah, she'd have to start over again, but the previous elimination from the program for smoking is not held against her in any way. She's a non-smoker now. She's welcome. Please come back.
Excellent. Thank you. Diana would like to know what the follow-up with the surgeon after surgery. For example, is there a yearly follow-up or once recovered and no further follow-up with surgeon?
Yeah, now we're like luggage. You can't really get rid of us. You just shove us into some back closet somewhere, but we never go away. The follow-up is 2 years, is 2 weeks after surgery, 6 weeks, 3 months, 6 months, a year, 18 months, 2 years, and then yearly for at least 5 years. I have a physician assistant who does the bulk of those appointments. You see me mostly up front when you're still freshly healing. And then if there's problems down the road, he just sends you right back to me. Or oftentimes he's seen you when I'm there and I can just run over and stick my head in. But yeah, no, there's extensive surgical follow-up and it's necessary and it's good practice.
Thank you for that. Ashley has some questions, but I'm not seeing them. So I just sent her a note that if she could retype them in. And if you don't mind, I'm just looking through a couple of spots where her questions might be. I'm not seeing any more questions coming through. I'm so sorry, Ashley. If you want to email me your questions after the program. Oh, well, here's another one while Ashley's trying to get through the Q&A. Diana would like to know what would be our next steps if we're interested in the program.
Absolutely. Thank you for that. The phone number to call is 794-7020. 794-7020 is the phone number to my office. And tell them that you're interested in the weight loss surgery program and that you want to sign up for an information session. That's the first step in the program. You're obligated to nothing, so it's important to know that. You could do the information session and go, oh, this is not for me. That's okay. It's for you to learn. And that's really all that you're going to get out of that is to learn a little bit more about this. So by all means, come to an information session, 794-7020.
Ashley has, I think, some good comments that she needs to discuss personally. So I'm going to recommend that Ashley, that you call Dr. Romanelli's office regarding what you can do. And the number again, Dr. Romanelli, was
794-7020.
Great. Okay, well, I think we're complete with the Q&A. I don't see any more questions coming in, but a lot of great questions. And and Diana's asking if it's area code 413. Yes, it is. Diana.
Yes, it is.
Yeah.
Sorry about that. Yes.
Yes. Oh, Ashley. Okay, one more question. Ashley is asking, is it common to have a hard time re-losing after gastric bypass?
Once you've had a bypass,
yes,
and gain weight back and then losing again,
yeah,
it depends on why the weight was gained. So if you're not dieting and not exercising, if you start dieting and start exercising, you lose weight. It's not always that simple, and I wish it were. So I guess my answer is it depends, because that could be dependent on medical conditions as well. Like, for example, let's say you became severely hypothyroid, then it might be very difficult to lose the weight, even though you have the anatomy. So I guess it would depend, you know, or let's say, God forbid, you know, you lost a parent and it became an incredible stress. And for a year you dealt with, you know, losing mom or losing dad. You know, when your mental health takes a big hit like that, things like trying to lose weight take a back seat. So, you know, until you're mentally healthy, you won't be able to focus on your weight. So, you know, it depends on the reason. The outside factors that influence this are pretty significant in life. And so it would really depend on why you were no longer losing weight. I see that all the time. Life is a funny way of getting in the way of our best plans, and that's totally true with trying to lose weight as well.
So Ashley said thank you and that she's going to give you a call.
That's
And
fine.
then Diana said thank you for your time, exclamation point, very helpful. And we're
Thank
at
you.
time for the event. So Dr. Romanelli, really wonderful information. And
Thank
thank you for helping all of us.
Thank you very much.
Have a great evening.
Okay. Bye now.